Thanks for joining in and participating in this webcast of Making Dollars and Cents of Social Determinants of Health. I'm Jeremy Cantor from JSI. I get a little anxious when I have to talk for more than 3 minutes without any audience response. This was originally intended to be a conference session and then a webinar where there would be some live Q&A, and now a static webcast. So I'm going to imagine all of you out there, and please don't hesitate to follow up with me if you have questions around any of the content. I'll provide contact information at the end of the presentation. I'm going to talk for about 20 minutes. It's sort of a high-level, broad perspective on the field and social determinants of health. Obviously, as a disclaimer, things may have changed in federal policy between the time that we're recording this and the time that you're listening to it that would have a significant impact on social determinants of health and the implementation of initiatives and funding for social determinants programming. So let's start from a broad perspective and putting social determinants of health in context. Many of you have probably heard the story of Jack Geiger and his pioneering work setting up some of the first community health centers in the United States. This is a picture of Dr. Geiger and Dr. John Hatch at the Tufts Delta Health Center in rural Mississippi, where they moved from providing both high-quality clinical services to addressing social needs such as food insecurity and exposure to infectious disease such as hookworm from individuals walking through the community without adequate shoes. When a federal regulator came to check out what they were doing, he'd heard that some unorthodox activity was taking place at the health center. He found that they were actually stocking the pharmacy with fresh fruits and vegetables paid for with federal dollars. And he raised the question, what are you doing? This is not admissible. To which Dr. Geiger responded, the last time we looked in the book, the specific therapy for malnutrition was food. So the emphasis on social determinants of health, an awareness of the importance of community factors in determining health is really baked into the community health center movement from the beginning. And when we talk about social determinants of health, we're really talking about drastic differences in social conditions resulting in dramatically different outcomes. So what you see here is a map of Alameda County, where I live, coded for life expectancy. So you can see the dark areas with the lowest life expectancy, 72.7 years, the lighter areas up to 82.7, so a 10-year difference here. And actually, when the Alameda County Department of Public Health ran the data, what they found was that a white child born in the affluent hills of Alameda County could expect to live over 15 years longer than an African-American child born in the flats, the darker areas of this map. To the right is a campaign that many of you likely have seen that the California Endowment put together looking at life expectancies in zip codes across the state, really highlighting this, this huge discrepancy. Some of this may be due to access and quality issues around healthcare, but largely we're talking about a whole range of other environmental and social conditions. There's another way to look at that. This is a map of part of Los Angeles County, and what you see here in the red is the Health Disadvantage Index. The green is Cal EnviroScreen, and the blue is both, is areas of highest disadvantage. These are two composite scores. And unsurprisingly, there's a lot of overlap And if you start to layer on other factors such as Medi-Cal enrollment or disease prevalence, you see the same sort of map. And so what we're really talking about is concentrated areas where multiple disadvantage factors are at play. And you could as well overlay rates of chronic disease, of course, and see a very similar pattern, the same communities, the same neighborhoods, the same individuals. So when we're discussing social determinants of health, to some extent, we're really talking about etiology. We're talking about reclassifying disease, right? We can think of in terms of the leading causes of death over here on the left side of the screen and link those back to risk factors such as tobacco, alcohol, diet, physical fitness, social fitness. And then those link back to determinants of health. Now, obviously, there's complexity in moving from the left to the right of this chart. And it's harder to track these linkages. When you see somebody with a disease, it's fairly easy to categorize. At the same time, by moving from left to right, we are expanding the population, and we can start thinking about strategies that will affect multiple people. And as I'll talk about in a little while, that may actually be more efficient and effective at improving health. We're also talking about social policy writ large. So there's some really interesting research that came out of Yale a few years ago. This is from a book called The American Healthcare Paradox. And they looked at the ratio of healthcare and social spending in the United States compared with other developed nations. And what they found was that the United States stood out in that whereas in other countries the ratio was roughly $2 for social services to $1 for healthcare, in the United States it was flipped. $1 for healthcare, 55 cents on social services, so 2 to 1. And here's another way to look at that data. And you can think about this in terms of there's a choice. There's an implicit choice here in where we're putting our resources, and it means that healthcare, to a great extent, is picking up the pieces, is trying to remedy long-standing, deep-seated social issues that are occurring because of those accumulated disadvantage factors that we looked at in the map at the end. Largely, once individuals have been exposed and have experienced or are beginning to show the indicators of injury and disease. Lastly, in terms of the context, we're talking about resources. And I often hear people say or hear it commented on that that it's really hard to figure out whether working on social determinants, working in public health upstream saves money. And I think that's mischaracterizing the problem. And so let's talk about the issue of tobacco for a minute. California is at the vanguard of efforts to control tobacco and reduce tobacco consumption rates. Have been very successful. And UCSF's analysis discovered that based on a $2.4 billion investment, $134 billion has been saved just in the healthcare system. Doesn't even account for savings in terms of productivity or tax revenue from increased consumption, etc. $134 billion. I don't know where that money is. I'm guessing that most of you haven't seen any of it coming into your budgets either. And I think what that indicates is that it's not so much an issue of there not being money to be accrued, but that we haven't figured out the mechanisms for capturing those savings. We've got what some people describe as a wrong pocket problem. The investments happened on the prevention side, and the savings happened in various parts of the system without a mechanism for reinvestment upstream. So we're seeing growing interest in social determinants of health across the health sector. And I want to talk about a few of the factors that are at play and are driving that interest, and the indicators as well. So, just on its face, I've got a whole file full of these headlines and see them every day. Big health systems making large-scale investments in communities, in social programs, in social determinants of health, connecting patients to social services, a whole range of investments. We're also increasingly seeing physicians commenting on their desire to better address the social needs of their patient populations, as well as feeling that they need new skills and new tools in order to adequately address those needs. There are large national and state initiatives that are investing billions of dollars in initiatives that explicitly focus on social determinants of health. The two examples are the Accountable Health Communities Initiative out of CMS and California's Whole Person Care pilots that have just launched this year. There are changes to the payment landscape, and we'll go into this a little bit more in a few minutes, but essentially the move away from fee-for-service reimbursement and towards value-based payment is also opening up opportunities for investment and consideration of social factors. And we've got a host of evidence from initiatives that have launched in the last 5 to 10 years. So around one issue that we'll talk about a little bit more later as well, housing. There is a robust evidence base indicating that that investments in supportive housing reduce healthcare costs. The figure on the left is from a federal review of initiatives in 5 states, and found huge reductions in costs over 1 year after admissions into supportive housing. And this is among primarily high utilizing individuals. Here in California, we've got a number of initiatives. One that I've looked at somewhat closely is Project 25 in San Diego, which is an attempt to identify the 25 highest utilizers. They ended up actually with more than 35 participants in the program, and to break the cycle of emergency room usage, criminal justice usage, substance abuse, etc. And what they found through a program that focuses on whatever it takes approach and an extremely low client to staff ratio, really working very intensively with these individuals, that they could achieve a net savings of over $33,000 per participant per year, and have now contracted with Medi-Cal plans to provide services for some of those high-cost individuals. There's a robust collection of practice examples as well. Here are 2 reports, one on social determinants of health initiatives, the other specifically focused on what community health centers are doing, and there are many more. So the practice and the capture of these sorts of initiatives is going on, and again, there are many more of these. If anyone has a specific type of initiative they're looking for, let me know, and I'm happy to either send something that I already know of or do a little bit of searching for you. And one of my favorite new websites is the recently launched Social Interventions Research and Evaluation Network out of UCSF, funded by Robert Wood Johnson Foundation. And this evidence library is a great, easily searchable resource that includes dozens and dozens of recent peer-reviewed literature, around this topic. What's working on social determinants of health? So if you have a specific issue, social determinant that you're interested in, a specific population, or context in which an initiative is run, this is a great place to search for that evidence. So let's talk a little bit about developing a social determinants of health initiative and what goes into that. First of all, there's the issue of diagnosis. Understanding which social determinant are we talking about, which one is important. So here's one schematic that was put together by the Kaiser Family Foundation. There are many others that are like this, but the basic point is there's a really wide range of social determinants, and where there's a strong correlation to health outcomes, and that may be domains for intervention and health improvement. It's also complicated from the vantage of a clinical encounter to understand which of these social determinants is at play. This quote is from Dr. Laura Gottlieb, who's the director of that Siren network from the previous slide. I had diagnosed abdominal pain when the real problem was hunger. I confused social issues with medical problems in other patients too. In one older patient, I mistook the inability to read for dementia. I had neither the skills nor the resources for treating them. I ignored the social context of disease altogether. And there's lots and lots of evidence around the sort of context and relationship to disease. For instance, hypoglycemia increases toward the end of the month when patients run out of food stamps. It makes sense, important to consider in thinking about working with patients and designing social determinants interventions. There's a clear relationship between unmet basic resource needs and a wide range of chronic diseases. So we could talk for hours about data collection and how to identify priority social determinants of health in a patient population. So I'm just going to give you a very quick thumbnail overview of some of the approaches that are out there. And again, if there are questions, please don't hesitate to follow up. The Prepare tool is being rolled out, and CPCA is very involved in this process. The social risk screening tool, the protocol for responding to and assessing patient assets, risks, and experiences. A pretty comprehensive look at a long list, not all of, but many of those social determinants in that original Kaiser Family Foundation slide. There's a move to look at how to integrate social and medical data. Down here on the bottom left is an article that I worked with on with a few other partners at UCSF around this topic, and specifically how to use ICD-10 codes as a translator between some of these tools like Prepare and EHR tracking. There are also less data-intensive ways to identify priority conditions. So there are community health needs assessments. There are other ways to identify priority community health conditions, and there are lots of examples of clinics, hospitals, health plans identifying priorities based on patient surveys or community outreach. So there's a real range from very intensive data-rich approaches to much quicker approaches using existing data and processes. The second component is to design the treatment. So once you've identified a social determinant of health, an issue where you want to intervene, where to intervene. This schematic is from the Bay Area Regional Health Inequities Initiative, showing the pathway from upstream factors to downstream factors related to mortality and disease and injury. And I think this is a good way to sort of approach and think about this issue of intervention, right? There are intervention points at every point on this continuum, from disease and injury back all the way to social inequities. And it's a critical question to ask in thinking about designing a social determinants of health intervention. Where to intervene? Where do you want to intervene? What sorts of capacities do you have to carry out an intervention at that point? Partnerships, etc. Let's think about this in terms of a specific issue. So back to housing. We can think about housing strategies in a lot of different buckets. I've broken them down here in terms of thinking about what can be done in a clinical context, in a clinical community context, and a community environmental context. So in a clinical context, you can collect data, make referrals, provide information, treat symptoms. There are a number of other potential strategies that could make sense here as well. In a clinical community context, there may be a handoff to a housing org, an assignment to a community health worker or a public health nurse to follow up and remediate troubling housing conditions through maybe air filtration, providing a vacuum cleaner, remedying mold in a house. And in a community or environmental context, there's an opportunity to collect population data, really looking at the entire population, to form partnerships to pursue policy changes, etc. The three diagrams on the bottom are all from St. John's Well Child Clinic in Los Angeles. And to really quickly tell the story of their housing work, a number of clinicians at St. John's identified a cluster of symptoms among their pediatric population, from respiratory illnesses to rodent bites to cockroaches in children's ears, and began collecting data on an intake form to identify housing issues. They identified a range of factors that were related to housing, really recharacterizing these clinical conditions as housing issues. And through a robust partnership with a set of community-based organizations and public agencies, set out on a campaign to remedy the issues, not one patient at a time, but rather by going after slum landlords. They identified with that there were specific landlords who were responsible for deteriorating housing conditions that were causing this clustering of health issues among children. And they were extremely successful in doing that, improving health among these individuals, improving behavioral health and stress and anxiety as well. If you get a chance, the Shame of the City report is a great read about how they approached this and successfully put pressure on landlords and improve conditions. Looking broadly at the landscape of potential interventions along that kind of continuum, there's growing and pretty solid evidence that environmental interventions are generally more cost-effective than clinical interventions or non-clinical person-directed interventions. So obviously, there are complexities with doing that sort of work. And one of them being that there isn't a natural funding stream for doing the type of work that I just described that St. John's is doing. So again, we come back to this sort of wrong pocket problem and how to unlock the resources and support for some of these more effective and more ambitious social determinants of health interventions. So this webinar is titled Making Dollars and Cents, so let's talk for just a couple of minutes about financing social determinants of health. There's no easy or ready-made answer. This is an area where there's a lot of thinking and work going on, and ideally there'll be some new models and strategies moving forward, many of them developed by those of you who are listening right now. First, as I mentioned before, we have a changing payment landscape. Nemours did a comprehensive review of activity in states across the country to lay out a roadmap of Medicaid prevention pathways. And one of their conclusions was that it would be much easier to design prevention initiatives in a managed care environment as opposed to fee-for-service, based on the flexibility that MCOs have to cover additional services and to credential non-traditional providers. We're also seeing bubbling up of conversation around social determinants of health risk adjustment, similar to the risk adjustment that is done for age, sex, and disability status. Mass Health in Massachusetts has proposed a risk adjustment model for MCOs and ACOs to adjust their global capitation rates, and the 4 risk adjustment factors here on the right are the 4 that they proposed implementing. There has also been a call for pay-for-performance contracts to be adjusted based on social factors, particularly where there's a conceptual and evidence-based link to outcomes. There are opportunities to leverage existing and new mechanisms. So depending on the population of focus, there are a number of initiatives either launched or getting set to launch in California, from health homes for patients with complex needs focused on the very highest utilizers to whole person care, accountable health communities, and then the confusingly named Accountable Communities for Health initiative that's looking really at communities as a whole, as well as some emerging guidance around the use of care management, enabling services, TCM and MA, community health workers, etc., that may be leveraged to support social determinants of health initiatives. Most of the strategies and funding mechanisms described on the previous slide relate to clinical or clinic-community interface strategies. There's also a growing interest and investment in cross-sector partnerships focused on improving health at a community, population, or geographic scale. So I mentioned the California Accountable Communities for Health initiative. This is an initiative funded by a consortium of funders to support 6 communities across California in implementation and 10 more communities to do capacity building, with the idea of creating a platform, a venue for cross-sector decision-making and integration, alignment of strategy to address some of these social determinants of health that we're describing in a way that achieves measurable outcomes and ultimately works out a sustainable funding model. Think through some of those wrong pocket problems that we described earlier. Because healthcare is one of the players in this ecosystem, but many of these strategies really have to do with improving conditions across sectors. So it may involve housing, or there may be savings that accrue on the criminal justice side. And there's a real need and opportunity to figure out how to partner effectively across sectors, to share resources, braid and blend funding, share data, and ultimately align efforts toward a set of collective goals and outcomes. So I want to close with another quote from Jack Geiger. I believe it is time for community health centers to return to those early initial models that saw healthcare as an instrument of social change. Access to good clinical primary care should remain their central contribution, but their task is incomplete without this broader social effort. And as we move toward increased engagement with social determinants of health, I really hope that, and I think it's essential that community health centers be at the center, given the historical commitment and genuine connection to communities. In order for these initiatives and these investments to be made in the most sensible way, community health centers need to be part of the strategizing and implementation around addressing social issues. I've included some resources here. There are many, many more. And again, I encourage you to reach out. Let me know if you have any questions, any specific resources that you're looking for, or want to discuss your own approach and thinking about where you are going to go with social determinants of health. Thanks again for listening, and I hope to talk to you soon.